The views and opinions expressed in the following program are those of the participants and do not necessarily reflect those of KSMQ Public Service Media Incorporated or its assigns.
Over 60% of healthcare in America is delivered by rural healthcare facilities and practices with 10 or fewer doctors. This large majority of healthcare is being completed with shrinking budgets and ever smaller numbers of providers. These combined constraints, along with ever-increasing healthcare regulation, make running a rural medical facility a daunting task. Today, we are joined by CAO of a rural medical center. I'm Sean Riley, and you're watching Health Connections. Today we're discussing the challenge of running a rural medical facility. Joining me from Austin, Minnesota is Mr. Adam Reese. Mr. Reese is the Chief Administrative Officer of the Austin Medical Center here in Austin, Minnesota. Adam, welcome to our show.
Thank you.
So Adam, tell us, what exactly is a Chief Administrative Officer?
Well, you know, these titles and these positions are slightly different from healthcare center to healthcare center. I'm a part of the Austin Medical Center, which is a wholly owned subsidiary of Mayo Foundation. And the way Mayo works is they like to work off of a partnership. And we believe strongly in physician leadership. So we have a physician CEO, Dr. David Agater, but our physicians are practicing physicians in addition to their leadership activities. And so they always pair them up with a non-physician who's a professional business person who helps with all of that side of the healthcare system. And so I'm the counterpart. I have a master's in business administration, and I try to support then all of the various financial and HR and all the other kinds of support functions that enable the physicians and the nurses to be able to practice the medicine that they need and want to practice.
So you really end up being you're the top dog other than the CEO physician, really?
That's true, right.
Okay. Okay.
Yep, Dave and I, we've got a great partnership.
Great. So healthcare in the United States is changing massively, and there's a lot of difference in between what has been this urban large medicine versus rural healthcare. So what are some of the services that you would say are unique to rural medicine in a facility, something like Austin Medical Center?
Well, I think what you tend to see in rural communities is more of a focus on primary care and some specialties. But when you get into the larger metropolitan areas, especially a lot of academic medical centers, you'll see lots of specialists and subspecialists. And so, in fact, the way people even interact with medical centers tend to be a little bit different. In the urban areas, you see a lot more visits with specialists, and in the rural areas, then it tends to be more of this primary care focused, and certainly use of specialists, but maybe in a little more of a sparing manner.
No, when we say medical center, it's a term that isn't used a lot. You always see hospital, clinic, etc. What exactly is a medical center versus another facility?
Yeah, no, that's a good question, Sean. And sometimes I forget I've been a part of this Mayo system for almost 25 years. Mayo actually believes wherever possible in an integrated, and that's why they use the term medical center. And what they're really talking about is a hospital and a clinic combined. They could be under one roof, but if not, they're administratively managed together. We try to have a single board, for instance. And so we try to avoid the competition that can result when you have independent physician practices, hospital. They may duplicate duplicate, for instance, radiology and lab and other kinds of services. So the Mayo model, we believe strongly in this integrated approach because we believe we can be more efficient with the resources that we're using. We also believe that we have this opportunity to try to focus on the entire care continuum as that patient enters whatever kind of care they need and exit, because it's all ultimately managed under one single entity. We hope to try to coordinate all those pieces.
Okay. Is that more common in rural settings, or is that just a general change in healthcare across the country?
Yeah, well, I know a lot of your listeners are from the southeastern Minnesota area, and Minnesota is unusual, especially southeastern Minnesota, being home to Mayo Clinic, which is really the founding organization. Basically, Mayo created this whole multi-specialty group practice, and was one of the earlier clinics actually to then completely merge with their local hospitals, St. Mary's and Methodist. And so what you tend to see in the Midwest is a proliferation of this Mayo approach to the multi-specialty practice, very integrated leadership structures. Now, having said all that, what's happening now throughout the country is there's more of that going on. But there are still plenty of markets where you have separate physician offices, separate hospitals, and in fact, you wouldn't even see a group practice the way we like to think about it in this part of the country, but actually independent. You'd have a group of, for instance, primary care docs, another group of maybe they're general surgeons or orthopods or ophthalmologists, and what again is more common in this particular area, and I really do attribute a lot of that to Mayo, is everyone working together under one roof.
So this really ends up being a best practice for the patient. That they get a much cleaner continuity of care. They get access to both clinic and hospital with integrated services for them. So it really is a best practice.
Well, we certainly believe that is, and I recognize there are different models out there, but it is interesting that more and more parts of the country are moving towards this practice. So I really think there is something very attractive and value added in this approach. We also know, listening to others around the country, certainly with the healthcare reform debate, President Obama specifically mentioned Mayo Clinic on more than a few occasions. And so Austin Medical Center, being a part of the Mayo system, is following that model lockstep.
Okay. So rural healthcare facilities face all sorts of challenges, and in some cases different challenges than urban facilities with, and things like ensuring access for patients and recruitment and retention of doctors, low payments from government payers, those type of things. What do you see as being the most significant challenges for facing rural hospitals, especially in southern Minnesota?
Right, and I heard you use the word rural hospital, and I'm just going to reframe it because of our approach is the integrated. So we're referring to it as the medical center, but the same would be true for a rural clinic or a rural hospital, and probably there are more than a few challenges facing them. I would say probably one of the biggest challenges is recruitment of physicians. We know there's a lot of research, and certainly in our efforts at recruitment, people coming out of residency programs, most residency programs and medical schools are in large metropolitan areas, and so there's a desire to stay in that kind of environment. So the kind of individual that is going to be choosing a rural area that's really a smaller population, and typically they're people actually from smaller towns that perhaps went to to study at whether it's the University of Minnesota or some other very good medical center, medical school, but then have chosen I want to come back home. I want to be with my family and my neighbors and so on and so forth. The challenge then is, how do you attract someone to come back when, for instance, if they have married a spouse who has a a very professional person, and these smaller communities just don't have the same kind of economic base. You know, there may not be that opportunity that that person would find perhaps in the Twin Cities. So we have some of those challenges. Some of the other challenges we have are frankly on the reimbursement side, Sean, and that is that for the most part, our government payers are actually paying us less, and in some cases significantly less, for the exact same services that are being provided in metropolitan areas. And so, so with fewer dollars, a challenge on the recruitment side, and then on top of that, the rural communities have been hit quite hard in the recession. They tend not to have the very large international corporations that can seem to sort of weather any kind of storm, and so that poses some real local challenges. And so it's not unusual in rural areas to have high unemployment, and then of course there's a lack of insurance options for them, and so on and so forth. So there can be a variety of unique challenges in the rural setting that the metropolitan areas have. And I could go on and on about transportation. You know, we tend in rural areas tend not to have public transportation like you would see in a metropolitan area, and so that creates unique challenges perhaps for our elderly. So you know, I think they're there, but at the same time, you know, the organizations like ourselves that are in rural America, we love it. I mean, that's why we're here. The people, whether it's the physicians, the administrative folks like myself, our nurses, all the other support people, we're attracted to perhaps some special, unique, we consider very positive qualities in the rural environment. Maybe a slightly different pace of life, certainly a lot of open land. People have hobby farms. Oh, there's all sorts of advantages for children and so on and so forth. And so some of us feel like we can do the best of both worlds. What we find unique at the Austin Medical Center is because we're a part of this sort of world famous Mayo Clinic, we have some unique advantages to draw upon all of their expertise and talents. I can expound upon that later if you like. But that has really helped us, for instance, in recruitment. So when we're recruiting, yes, we're recruiting to the Austin Medical Center, but we're recruiting to the Austin Medical Center that's part of the Mayo Health System.
Sure.
And physicians like that connection. They like the fact that they can have this relationship with all sorts of specialists to help support their practice. Educational opportunities are just endless, and so that opportunity to sort of continue to grow professionally is a very powerful attractor. So despite all the challenges, we, at least within Austin, have done fairly well recruiting.
Very good. So I'd like to touch on that point with Mayo Clinic, but before that, you mentioned that there's a payment disparity in urban centers versus the rural centers. And I think the general public would look at this and say, well, if I'm getting an appendectomy done in Minneapolis versus an appendectomy done in Fairmont versus La Crosse versus Austin, they would say, well, it's an appendectomy, isn't it? The general public would ask, why is there a disparity? Any thoughts to that of why is it that those urban centers are getting paid more than the rural centers?
Yeah, you know, of course, I have the bias of the rural side of the equation, and I'm sure my counterparts in the metropolitan areas would say, well, but Adam, you know, our property's perhaps more expensive, and so on and so forth. But the interesting thing is, when you really think about the cost structures, there really isn't significant difference. While it's true land may be less in a rural environment, our biggest expense is people. And for people, we have to retain and recruit folks with market competitive wages. And so if our salaries for a physician aren't competitive with anybody else within the area, and that includes all the metropolitan communities. They just won't. They won't come and work here because people want to be paid fairly, and I think that's perfectly reasonable. And in fact, if anything, some of our physician expenses are a little bit higher because there is a greater demand for the Twin City, for instance, openings. Their salaries typically are a little bit less.
Do you see the same problem with the other staff, say whether that be nursing or pharmacists or IT folks or whatever? Do you have the same problem?
Yeah, I mean, it's a good question. That's not true for all areas, especially positions where there is very much a local market, and if there is a local market, then we can try to fit into that as best we can. But the minute we start to look at a particular position, and pharmacists might be another good example, anywhere where there is significant demand, and these people really can go anywhere and work in the country, frankly. We again are starting to look at not a community-specific market analysis for wages and benefits, but maybe more of a regional. And so there are some examples where the labor costs may be a little less, but others where they're right up there.
Okay. So with this payment disparity and this higher cost for your production labor, your physician labor, does the rural quality of care suffer, or is it relatively equivalent to urban centers, or how does that weigh out as well?
Yeah. And the other one I just want to mention is that an MRI machine or CT scanner or blood gas analyzer, these large companies don't go, oh, you live in a rural area, we're going to give you the special deal. So all of that stuff is the same. In fact, if you are a small standalone clinic, hospital, even an integrated system, but a standalone, you don't have much negotiating power. So in fact, you actually may be paying more for a lot of the high-tech equipment. Now, of course, those of us that are part of a larger system, such as Mayo, we can take advantage of those larger buying contracts, and then that's really a blessing then to these smaller rural areas like Austin, for instance. We're getting the very best prices on incredibly expensive equipment. But so I apologize, I digressed here for a moment. But you want to focus more on the quality piece itself.
Is the quality of a rural facility, given they've got these other additional challenges, is that quality of care, if I'm a patient, should I still be looking at my local rural site, or should I say, oh, I need to drive to a bigger city to find health care?
Right. And I would say it depends. I believe that everything we do, for instance, has to meet Mayo standards. And so I have no question that any service at the Austin Medical Center is providing a standard of care and quality and safety that people truly can feel comfortable about and know that if they're getting a cataract operation, for instance, at AMC, that would be the same level of quality as in Mayo Rochester. In fact, that particular example is sort of an interesting one. Our two ophthalmologists, now one is just leaving and we'll be getting another one, but in both instances, they're both Mayo trained, so same level of training as the Mayo ophthalmologist. They're using basically the same equipment, the same setups in the OR, and so on and so forth. Certainly with primary care, we feel very confident. We're measured in numerous ways with publicly reported data. We certainly feel that our quality is as good. However, when you get into more specialized care and especially subspecialty care, we're not going to offer those services because we won't have, first of all, it's very hard to attract someone, and would the community really be able to support that kind of specialist? What we tend to see is as care gets more specialized, you need larger and larger population bases to drive enough demand for that unique specialty, and for specialists to be very good at what they do, they need to do a lot of it, and so that in those cases it really makes sense to go to the larger tertiary medical centers for those types of procedures.
So something like a chronic disease, diabetes, perfectly good going to a medical center, but if you're looking at maybe brain surgery, need the neurologist, you're thinking go to your medical center, your local site, and get referred out to that tertiary system, maybe that larger environment.
Right, and I think the individual would have two choices. One would be to be referred out through a local provider, maybe a family doc, or it could be a more general specialist, like a general neurologist in the instance you brought up. And or they always have the opportunity to just drive directly to wherever that might be in the Twin Cities or in Rochester, Mayo. Either way. One of the attractions, though, I think of the rural setting is an opportunity to really get to know your provider, and a number of our physicians and nurse practitioners and PAs have been here in this community for quite some time, and so it's not unusual for someone perhaps to have been seeing a physician for such a long time that their children see that physician, and maybe their parents have seen that particular physician, and that continuity there's a certain attractiveness to that.
Sure, it adds to that familiarity of people and gives them that real family doctor feel versus the kind of put them in, put them out type of feel that you get in a lot of places. So
yeah, and I think that's what the rural centers always try to pride themselves on, is sort of a very personal touch in everything they do, and not unlike the old hardware store. It's the neighborhood hardware store where they know you and they know, oh yeah, Reese is coming along. He has that old lawnmower that always breaks down, or something like that. And so I think that's certainly attraction. But bottom line though is, and because I know some of your viewers may be in communities far away from this particular area. I would always encourage them to do their research. If they don't feel comfortable with whoever they're getting their care from, they really should look at options. And hopefully, in today's environment now, there may be a little more data. They could certainly ask if they were under the care of a local provider and they needed something a little more specialized done. Have you done that procedure before? How many have you done? And ultimately they need to feel good with the decision they're making.
Now, you mentioned all the advantages of Mayo Clinic, and you've said quite a few actually already. The quality enhancement, because you can go from site to site, and I can give a perfect example. You said cataracts. I had LASIK surgery last Friday.
Okay.
I had part of it done at Austin Medical Center, the pre-work done at Austin Medical Center. Then I went to Owatonna Medical Center, or Owatonna Clinic, for the actual surgery, and then I'm having post done in Rochester because I happened to be there that day. And I get the exact same quality going from site to site. What are some of the other advantages that Mayo really gives you?
Yeah, boy, and I've been a part of the system so long, you start to take it for granted. So if any of my colleagues are listening, I apologize for not being as inclusive as I should be. But from an administrative standpoint, I just have to tell you, medicine has become unbelievably complex. I used to work for another part of the organization, and the CEO there said, and this is quite a few years, this is a good 10 plus years ago, he said at that time there was over 300,000 pages of Medicare rules and regulations, and you can imagine a smaller rural medical center, how do you manage that level of bureaucracy? Well, you do the best with what you have, but we have relatively small business offices and so on and so forth. But again, because we're part of the Mayo system, Mayo has a whole Medicare strategy unit. And these folks, that's what they do. They spend all day reading all of that stuff and helping make sure that we're complying with all the various rules and regulations. And I think when mistakes are made, they're not made intentionally. There's just the level of bureaucracy is so amazingly intense that you can make a mistake. And so for me, I find that very comforting, knowing I'm supported by these real experts on the administrative side. But I think for patients, though, they're much more focused on, the quality of care that I'm getting, and if there's a best practice, is that the practice that we're doing here? And again, that I feel is one advantage to being part of a world-class medical center, because we create specialty councils, and so physicians are working together, determine how should we do something, and how can we spread that knowledge, be it various protocols, could be equipment. There may be certain devices that have better outcomes than other devices. Certain implants, if you're an orthopedic surgeon, have better outcomes, faster recovery, and so on and so forth. And so again, being a part of that large system, we can really tap into that kind of wisdom. If safety's been a big initiative, we've heard about in medicine certainly mistakes being made, errors being made, and again, trying to learn what are the best techniques for organizations to embrace so that we can reduce that likelihood that any kind of error would be made on a particular patient. So many different elements.
Well, we're down to our probably our last question here as we're coming to the end of our half an hour, but I'll tie this, and I have one that I have to ask for maybe a really quick answer. But President Obama signed healthcare yesterday. There are now 30 million more people in the healthcare pool. Is this good? Is this bad? Rural healthcare facilities going to feel this more than other places? And I'll ask you just a quick answer, and I got one more question I want to get to you right before we
well, it's hard to respond to that quickly, but I think for us to fully vet the complexity of the reform that was just passed is going to take some time. So I can't go with a simple yes or no, but I think anything that improves access through more insurance options, I think especially in rural areas where there may be harder economic times, I think that will be good for those folks. I just want to say that most rural places, though, will see anyone, period. We don't get into the wars that take place in the metro areas. We do, at the medical center here, we do our best to try to take everyone regardless of their ability to pay. So in that case, I'd like to think that somebody may get care under some new Obama plan, but perhaps they were getting that care under a charity situation or some other approach. So we're going to do our best to accommodate people.
Okay. So then one other quick thought as we go. As we've seen the Mayo Health System, the Mayo Clinic have had excellent things in innovation. What is your number one project that you're innovating from Austin Medical Center?
Right now, medical home. We're really looking at sort of team-based, some innovative approaches to primary care, and we're excited about that.
Well, that's great. I think we're right at the end here. And Adam, I'd like to thank you very much for coming on Health Connections with us, and hopefully we can get Dr. Agutter, CEO of Medical Center, back when he is not ill. So thank you very much for coming on the show, and this has been Sean Riley on Health Connections.